and welcome everyone to today's session. And today's session is our fourth of the sessions we're having with our distinguished lecture series over this next over the 12-month period there. So welcome everyone to today, and hopefully in terms of tech everything goes well, but if not, we've got people on standby to support. But we've got a fantastic speaker session today, and going to be really pleased to introduce them and hear what they have to say and enlighten us on, really. So the focus on this session is on health tech horizons. It's about innovation in action, and we will explore how new health tech digital tools and technologies are tested and importantly then adopted into clinical practice. So what we're going to see, and hopefully going to see, is our distinguished panel will kind of help kind of consider what helps innovation move from kind of being that pilot into kind of being routine care, and how strong partnerships can accelerate that kind of digital transformation to ensure we have kind of better outcomes for our healthcare across West Yorkshire there. So a little bit of housekeeping. This session will be recorded, so anyone who can't make it today will be shared across the communication platforms for people to kind of listen to there and pick up on there. Please, could you just make sure you're on mute unless you want you're speaking? That's great. And if you want to have your camera on, that's great. I'd like to see lots of people's faces if possible, but I understand that people may not wish to do that there. And then we've got a short session at the end in which we've got you can post a bit of a Q&A there, but if you want to put some questions in the chat, that's fine, and Bex and I will try and field them throughout towards the end of the session there. So we've gone to the next slide, if that's okay. So as I said, we've got a kind of distinguished kind of set of people here today, and really looking forward to kind of hearing from them today there. They've all got a kind of a slot to kind of discuss what they've been involved with in their fields. There got Steve Russ from our PodDoc, is well known to people there. Also got Damien O'Boyle from Healthy.io, really good to see as well. Dame Barbara Hakin who's a health advisory consultant and former NHS England National Director. Really pleased to have her here today there as well. Unfortunately, Graham Walsh, who's the medical director at the Health Innovation Yorkshire and Humber, is unable to make today. So he sends his apologies, but clinical work overtook us today. But I'm sure he would have added a lot more as well to the discussion today. So hopefully today we're going to be looking to cover kind of real examples of innovation in startups and in artificial intelligence pilot projects, looking at how adoption of new digital pathways can improve access to kind of testing, how does system leadership and conditions enable sustainable scaling, and kind of understanding kind of lessons from the workforce engagement and digital inclusion there, to ensure that kind of we ensure we have a stronger innovation pipeline for our region across West Yorkshire. Next slide. So many of you may well have been on these sessions before. It's the Distinguished Lecture Series, and is work with the wider digital team and with the West Yorkshire Innovation Hub, and is working with the West Yorkshire Integrated Digital Data and Technology Directorate and the Innovation Hub there as well. And we've already had 3 sessions which have gone down really well, and we're doing this over a 12-month period there, in which we're bringing together national and international leaders on subject matter who are subject matter experts to kind of share their insights, their best practice and understanding of how digital data and technology and innovation will support the delivery of the NHS 10-year plan and the life science sector plan in the health and care systems within our West Yorkshire area here. So that's the context. Really pleased to see everyone here today. Time is short, so I'm going to kind of hand over, and our guests have all been given the kind of 10-minute rule, but we know that kind of varies a bit there, and that's fine. No worries about that. We'll try and manage that, and then we'll at the end try and do some question and answers with them as well there. And then, as I said, those who are not here today, there's a recording that will be going out. So with that, I'm going to kind of hand over to Steve, if you're okay, if you're happy for that.
Yeah, hi everyone. Thank you very much for joining. Before I get into this, I think I just want to pick up on something that was said right at the beginning around adoption. Ultimately, um, things are adopted by people, not the system. They're adopted by people in the system, and so the very fact that you've shown up to this call today is something that I want to thank you all for. Fundamentally, thank you for giving a shit about this. It is tough out there, and we do appreciate it. And Damien and I go back a ways, and he'd probably say it a lot more eloquently than I would. But you know, it's been a tough couple of weeks. So anyway, look, thank you very much. So next slide, please. Who am I? So I'm the CEO and co-founder of PocDoc. My background is not in healthcare. My two co-founders are scientists. I came into this having, done well, got lucky in other venture-backed ventures, and felt there was a real opportunity in this space with my two scientist co-founders, one of whom is my wife. I'm a father of three. All of them are Manchester United fans for their sins. I have recently taken up a sport called jiu-jitsu, which involves me getting well, I was going to swear there again, but getting beaten up quite a bit. And I'm actually now, within 11 months of starting, I'm going to be doing the European Championships next month, which is insane. And whatever, just why not do that? In addition to PocDoc, I created and host something called the Healthtech Hour, which is now one of Europe's largest health tech podcasts. We get over 300,000 streams a month now across all platforms and downloads from people in over 50 countries. I set that up to give health tech founders access to broadcast media coverage. I felt like the broadcast media industry in the UK was very limited to announcements and short messaging, whereas everything that the amazing people in this space do is complex, detailed, but actually saving people's lives. So I set that up to provide that platform. I'm a huge fan of West Yorkshire, not just because PocDoc works with them, but my best friend from school lives in Wakey. So I've spent many an evening in Wakefield, obviously, visiting the museums and art galleries as opposed to some of the nightlife spots. But I'm a huge fan of West Yorkshire, and you can find me on LinkedIn or Instagram, where I share a lot of content and thoughts. I fundamentally care about what we do because my dad, who when he was the same age that I am almost to the day now, had a huge stroke due to undiagnosed cardiovascular disease. So I was 14, he was 43, and everything in our life changed from that moment. Obviously changed for him. He was in the Chelsea and Westminster for 2 or 3 months. He couldn't walk for over 12 months. We didn't know if he was ever going to get back into work again. And so he survived, but with very severe side effects. Obviously, from a personal basis, I can see the impact, but also from a kind of professional basis. I mean, he's cost the NHS well into 7 figures now. I mean, well into it for the sake of a £40 intervention 25 years ago. So that just doesn't make any sense to me about why we can't scale that solution, not just in our space, but in any space. And so, we've been very successful in what we've done with West Yorkshire, and I'm looking forward to taking you through it. I think the message that I would deliver to all of you here is that we've already done the work in West Yorkshire, and West Yorkshire ICB has actually funded it. We've already presented a business case as to how West Yorkshire can do more of this at a population health level. So, if there is anyone interested in talking about that, then we're all ears. So next slide, please. This is one of the things that I like to get out, and I get in trouble for this, but I write about the reality, having come into health from a non-health background. I was absolutely shocked about how it seemed to be okay to slag off your customer publicly in health in the UK. The idea that you could publicly criticize the NHS, who's your customer, just completely blew my mind. So I think that there's a huge dose in all of this concept of adoption. I think that there's a big dose of reality that innovators and innovative businesses have to take on the chin, which is the customer is ultimately right at the end of the day. And if the customer, whether that's an ICB or whether that's a region or whatever, isn't buying your product, then look first unto yourself before you start criticizing and moaning and going in front of select committees to say how terrible everything is. Apart from the fact that doesn't help anyone in the sector, it doesn't actually solve the underlying reason. So I'm a huge advocate for this kind of bipartisan discussion between the system and individuals in the system, but also from the company side. Just because someone isn't buying your product, it doesn't mean that they're not adopting innovation. Those problems are not the same problem. So that's just my take. And you can find a lot of this stuff I write. This post actually went viral. We got hundreds of thousands of impressions for this one. So, you know, that's just my kind of take on things, which I think helps inject a bit of realism into it. Next slide, please. Challenge in West Yorkshire. I'm pretty confident all of you are very aware of this. PocDoc is in the cardiovascular prevention space, fundamentally aiming to do whole population level programs. Probably none of this is a shock to you guys. I mean, the situation in West Yorkshire is also not particularly different than a lot of the places in the UK, because these are population health level risks. The great thing, if there is a great thing about cardiovascular disease, is if you can build a scalable, affordable, digitally integrated program, the health economics really speak for themselves, and the ability to address health inequality is baked into it, because cardiovascular disease is one of the major drivers of health inequality. So from a strategic commissioning directive, it hits a lot of bells and whistles if, and it is a big if you can deliver it scalably, affordably, and interoperably outside of GP surgery, or without overloading the GP surgery, without sacrificing clinical utility. So that's the essence of PocDoc and what we're aiming to do and what we deliver with systems. I think it's also worth noting that we deliberately focused outside of London when we launched. So the Northeast, the Midlands, West Yorkshire, South Yorkshire, Scotland, the Southwest. So we felt that London was particularly oversaturated with innovators, and was probably not a very fruitful place for us to start work. And that's borne out to be true. So almost all of our data has been generated outside of London. We've only recently started to launch projects in London. So next slide, please. Emily Turner, who many of you may have known, she's now one of our advisors, which we're super thrilled about, but she was the lead from the West Yorkshire side on the project that we've done with you, which was ICB funded community screening at scale, focused on areas of health inequality. So for example, Wakefield, Kirklees, a few places like that, predominantly outside of the GP surgery. So although it's been delivered with PCN staff in some instances, it's actually been delivered on the front line. So community groups, places of worship, sports grounds, community pharmacy, and so on, building together this integrated model of care, but delivering the screening without overburdening primary care. Next slide, please. So we are doing, this is kind of a snapshot of the program, if you like. So it's risk detection around CVD risks. So it includes, effectively replicates the NHS Healthchtech, but outside of the GP surgery. So full lipid panel, Q-risk3 score, heart age, integrations back into primary care for high-risk patients, focusing on being very specific about cherry-picking high-risk groups that we are going into. So for example, we know now that there are some groups which are likely to be to index really highly on this untested, untreated high risk sort of triumvirate. So anywhere up to 65 to 70% of the people that we're screening in some settings have Q risk scores of over 10%, and yet have never had a health check before or any kind of CVD check before. So those are the people that, like my dad, fundamentally, we really need to be finding affordably. And then we've developed this into a regional model, as I said, that we've now put into a business case and sent in to the ICB, and we're waiting for feedback on it. So if anyone has any feedback on it, I'd obviously be thrilled to hear it. But just mentioning that the results of this have been so strong that it's sort of, the business case kind of speaks for itself a little bit. Next slide, please. So I kind of covered a bit of this already, but it really aligns with the CLAW 20+5 mission. It allows you this combination of community-led screening with a digital platform, allows you to focus on the really areas you want to reach, but without sacrificing any of that tracking, interoperability, integration, and so on. One of the key barriers we know, particularly in certain cultural groups, is around accessing GPs. And this allows you to swerve that. And we've got great evidence of that. It allows you to drive early diagnosis, this left shift, which is what we're all trying to do. And it helps you focus on reducing health inequality. So I think probably the group that's joined this call over indexes, I suspect, on like agreeing with all of this. And I don't think that this is anything that's sort of often disagreed with. I think the challenge, if there is one, is about how to take all of the goodwill and intentions and channel it into projects that actually break ground and scale. That's the kind of challenge that I see. So next slide, please. This is a really good example of something that we've done recently to help our partners deploy. This is going to be showing up in Kirklees, I believe, imminently. So this is our neighborhood bus. I'm not saying that a bus is the solution to prevention. That's nuts. However, this bus, actually, we've kitted out with the latest technology. So this is actually, we have Starlink integrated into this bus. So this bus is fully self-sufficient, can write results into the record immediately from someone being screened inside it with our technology. So it's almost like a flag bearer for this idea of integrated community neighborhood care at scale. And we can deploy it to help our partners increase their usage and utilization of their tests. So think of it more like a kind of HGV cheerleader, if you want, rather than anything else. Like the solution to prevention is not to invest in vans, but this is a very good tool to try and drive activation and make a point around how integrating technology cleverly can remove some of these barriers that are traditionally placed in the way of community or non-GP-led screening initiatives. Oh, how does it get back into the record? This is how it gets back into the record. Oh, but how does it work? This is how it. So our job as innovators, to the point I made at the beginning, is not to tell the customer that their concerns are wrong. It's to continuously and rapidly solve those concerns in a manner which continues to make that product or service affordable to the customer. Next slide, please. So, like I said, these are some of the stats. 61% of patients tested who'd never had their cholesterol checked before, 60% had elevated cholesterol, and 99% found PocDoc more convenient than visiting their GP. And I would say that last one is PocDoc delivered by clinical teams, if that makes sense. So it's not just us out there in the wild. That's part of the program. But even as part of the program, the fact that they showed up in their pharmacy or their mosque or wherever it was considered to be, unsurprisingly, significantly more convenient than 2 or 3 in-person appointments at the GP, which is kind of the equivalent to deliver the health check. You know, it's one appointment that you have to make for the phlebotomy. The second appointment, you go back to get the results. And sometimes there's a third follow-up if the person that needs to speak to you about those results may or may not be there. Next slide. This is prevention at scale. We can skip this one. I kind of covered this stuff. We skip past that one. So this is the bones of the business case, and then I'll stop talking because I'm guessing I'm running out of time. But the scale of the problem, you've got about 250,000 people that we would consider to be the universe of at-risk people. If you screen just a quarter of these people, it can make a massive impact on moving that curve, right? So the whole point around screening is you need to find a way to do it at serious scale. Like doing pop-ups and stuff is all great, but it's not going to hit the curve. So this fundamentally, our business case is geared around how can you save 27 million as a minimum for investing less than £1 million. So this is a live business case. So if anyone's interested in kind of picking this apart, then I'm all ears. And you know, I'll kind of pass the baton over. If you go to the last slide. Oh no, yeah, we can skip past that one as well. That's just me saying what I said before. Thank you fundamentally for caring. You know. And without you guys, none of us would be anywhere. And if anyone wants to sort of pick up the baton of what next, then I'm all ears. But thank you very much for caring.
Excellent. Thank you, Steve. Thanks for your insights and your thoughts and your reflections there. Really, really important to hear, and we'll get on to those in the Q&A. But I will go straight on to Damien, if that's okay with you, Damien. But thank you.
Of course, and thanks for having me along, everybody, and lovely to see you. So Damien O'Ball, I'm the general manager at Healthy.io. Healthy.io is the first company in the world to turn the smartphone into a medical grade device. And I'm going to take you through, firstly, kidney. I will touch a little on wound, but I think important to state that around about you are annually supposed to have an albumin to creatinine ratio test if you have diabetes or hypertension, and what it's looking for really is protein. Early kind of indicator of chronic kidney disease is protein in your urine, and so I can tell you right now that across West Yorkshire, around about 40% of people with diabetes are not turning up for this test on an annual basis, and around about 60% of those with hypertension are not turning up for this test. And the problem with that is it's asymptomatic. So you can be walking around thinking you're perfectly fine, and actually doing tremendous damage to your kidneys. And you find out when you crash into A&E through a cardiovascular event, an acute kidney injury, or indeed, and that you can then lead up to requiring dialysis or indeed a transplant. So, and you can imagine that's a huge cost to the NHS. It's awful outcomes for the patient and a huge cost to the NHS. So, really, we set out with an idea of how can we identify those people before that happens. And if you think about the traditional method for urine testing, it's pretty gross, right? You go into your GP, you pick up a pot, you might go back home, pee in a pot, take a potential pot of warm urine back into your GP, to the receptionist, who puts on gloves, sneers at you a little bit, puts it to one side. 10% of those will get lost on the way to the lab, and that takes 3 days, at best 3 days, and people don't enjoy doing it. Think about the issues that can be involved there. Can I take time off work to go to my GP? Do I need a carer? What's the cost of getting to your GP surgery? I know I've spoken to many patients, and some will say it's a taxi to my GP. I'm not going to do this test. For me, it's not an important one. So how do we target those? The underserved cohorts that are out there. We've done that through Minute for Kidney. So I'm going to take you through this really quickly. I'm not going to do a live demo, don't worry, I'm just going to show you the kit. So here is Minute for Kidney, comprised of 3 very simple steps, really. So one is, firstly, designed to fit through any letterbox in the land. First is a pot that pops up like so. Very simple, just like so, just big enough to take enough urine for you then to dip a dipstick. And it's that dipstick there you can find in any GP surgery, an albumin to creatinine ratio dipstick. And then really the clever bit is this is the color board. So you can see that recess there. You put the dipstick in against that recess. And what this does is it adjusts for arbitrary light conditions. It adjusts for user behavior, and also for the phone operating system. And I'm sorry to tell you all this, but your phone camera is actually designed to make you look more beautiful than you actually are. So we have to downgrade that to get true color. And essentially, we're then able to give you back a lab grade result. So that entire process can be undertaken in 3 minutes in the comfort of your own home, and that result goes straight into the GP record. You get an instant result on your phone, instant result straight into the GP record. You're helped throughout by our avatar Emily, who's on the app, and designed really to enhance usability. She's got a 99.8% usability for 18 to 80-year-olds. We have had a 104-year-old patient complete an ACR test in the comfort of our own home using just a smartphone. I used to get lots of pushback in the early days about that's all very well and good, but Auntie Kathleen won't be able to do that. She'll never be. And actually, you find people do. They really can complete a test. We were funded through the Accelerated Access Collaborative and encouraged to get to as many people nationally as possible. As I talk to you now, we've got to around about 610,000 people have received this test across the country, across 23 ICBs, and around about 58% of those have completed a test at home. And just to give you a view on how strong that number is, when I first started, I used to work at the London School of Hygiene and Tropical Medicine, went back and kind of asked some colleagues there, what could we expect in terms of return rate? And they said, well, broadly speaking, it's a population health initiative, and then broadly speaking, you're going after the underserved, that you're going after people that are effectively disengaged from their own care. So they set us an aspirational target of 11%. So when we're running at 58%, we are so pleased to have reached that. And it's a combination of things. Over the years, it's been a lot of A/B testing, tweaking, feedback from clinicians, feedback from patients, and always looking for those kind of marginal gains to kind of tweak it up by 1 or 2%. Not trying to throw the baby out with the bathwater, but try to think about what can we just change to improve it. If we could just hop onto the slides for a second, James, because I just want to talk to just some of the numbers that we have in West Yorkshire. So if we go to the next slide, please. So there's the flow in essence. So we identify your cohort, we send them a test, they complete. A huge number of them complete under their own steam without any intervention, but we're essentially nudging them along to completion, and then they're categorized into those 3 areas. So they can be normal, don't worry, no action required; abnormal, worth further investigation; and then high abnormal. In each of those instances, we've actually got our own SNOMED code, so and we've hacked it a bit to provide the nice guidance, so it prompts the GP into taking some action, and they can take action. And if they can optimize that patient, you can get them onto a host of incredible drugs, ARBs, SGLT2s, which will essentially prevent progression of disease for decades. So you can really make a difference. And underpinning all of this is something that was born out of our initial pilot in Yorkshire. So we got York's Health Economic Consortium to undertake a full economic evaluation of Minuteful Kidney, and it demonstrates that ultimately, if you were to roll this out to the 1.4 million, just those with diabetes who don't turn up, so 1.4 million of people who are not turning up for this test on an annual basis that should, you would save the NHS 660 million net within 5 years, and you're doing that by preventing all those exacerbations and crashes into A&E. If we go on to the next slide, sorry, James, if that's all right. So initially, thanks to the Accelerated Access Collaborative, we were able to roll out across West Yorkshire, looking just at those diabetes patients. We got 140 practices onboarded. We got 16,350, just over 50% to test. This was kind of in our kind of initial rollout, and we identified 7,000 patients that needed some form of follow-up. And in an ideal world, the GP is following up with them, giving some lifestyle advice, or indeed putting them onto a drug. And then, really importantly, and this was an unforeseen kind of benefit, we thought would have some impact, didn't know to the extent. ACR testing is like any other health access issue. There is inequity, particularly traditionally you'll see the higher deciles getting much better access to care than those in the poorer demographics. And actually, what we were able to demonstrate through Minuteful Kidney is a leveling. So those in IMDs 1 to 5 get exactly the same level of access to ACR testing now as those in 6 to 10. So it was an incredible kind of piece of analysis that we thought was total gold. And then working with the brilliant team West Yorkshire, and I'll come on to thank them in a second. If you go to the next slide, please, James. We were then able to go after hypertension patients. So this was funded, partly funded through the HTAF fund, Health Technology Acceleration Adoption Fund. And we kind of said, right, we'll go after a hypertension cohort and let's see where we get to. So 70 practices onboarded. You'll see, I mentioned the kind of 58% adherence rate nationally. You can see West Yorkshire knocked it out of the park on hypertension here, getting to 63% adherence rate. And we've been really proud of this. I won't read out all the numbers there, but you can see that we then took it forward for a number of publications, actually, including UK Kidney Week. I just want to thank a number of the folk that have been involved in helping us do this in West Yorkshire, and I think it really does talk to some of the bits that Steve has mentioned around the importance of the people that are wrapped around any project or program that you put in place. So it wouldn't have happened without people such as Sunil Dagger, Wakas Tahir, Sarah DiBiase, Gillian Disney, Mark Wright, and Danny Robinson. And I can tell you that the real difference was that they were so invested in making this a success. That's why you've got a 63% adherence rate. Elsewhere in the country, you don't have that same kind of collaboration, that same strength of leadership, and you can see that kind of play out in how many patients you end up touching. So we were delighted with kind of the results from West Yorkshire, and we're still working through the kind of the hypertension evaluation in full at the moment. And then just to finish, that I did say I'd touch on wound. We've taken that same technology. We decided urine wasn't gross enough, and we went into wound care. Wound being a huge burden in the UK, around about the same cost as obesity and smoking, actually. 8.3 billion burden annually, but it doesn't fall neatly into any clinical condition. So we've taken the same technology and essentially using the color vision that was shown on the color board, you do a 3 to 5 second video of the wound, and it builds a 3D model of that wound, works out the tissue types within that wound, and suddenly you get objective measurement of wound, an accurate objective measurement of wound, but also you can start to then flag when a wound is deteriorating, when it's stagnating, and really start to then prompt better care around that wound. I will pause there. I think I've taken up my time. Thanks. Happy to answer any questions.
Excellent. Thank you, Damien. Really insightful. And yeah, there was a point there that we thought we were going to get a live demo, but thank you very much for avoiding that. But really good to hear, and we will have further questions on that. So, but with the time, what I'm going to do is going to hand over to Dame Barbara Haken. Thank you very much. I'll take it from there, and then we'll come back for some Q&As after that. Thank you.
Well, hello everybody, and thank you ever so much for inviting me to speak. Nice to see names, some familiar names. I thought I've got a slightly different brief than everybody else because I haven't got a specific example, and I probably bring more of an NHS focus than an industry focus, but I think nowadays I kind of can see both sides much better than I ever have done. So I'm going to just give a bit of a sort of strategic view about what could we all do better to get the innovations which are really going to make a difference to patients and save money for the NHS into place more quickly. A little bit about me. Some of you may know me. I started off life, I was a GP in Bradford for 20 years. And then moved quietly into sort of semi-management in the days of fund holding. And because in those days you could move money around and you could be light on your feet, there were all sorts of things that you could try out, which would be so much more difficult nowadays. But I then went on I became a full-time manager. So I ran PCT in Bradford, eventually moved into being an SHA chief exec. So I was the SHA chief exec in both the East Midlands and Yorkshire and Humber for a while. And eventually, when the Lansley reforms came about, I was kind of pulled down. You know, Mr. Lansley thought all GPs and doctors good, all managers bad. So I was pulled in to see if I could help manage him and pass myself off as still a doctor, which is, you know, when I kind of did my national career. But it is only fair to say that I think my national career was launched on the back of a whole host of really brilliant people in Bradford and West Yorkshire who helped me to do lots of innovations, which then got noticed. So it's really nice to be back talking to West Yorkshire again. When I eventually retired, I was Chief Operating Officer, Deputy Chief Executive, retired from NHS England, but I decided to do a portfolio career. I'd still want to work, I'd still want to help the NHS. And for some reason, I do have a number of clients who do more straightforward, just healthcare, but I appear to have drifted into working with a lot of companies who have some sort of digital or technology example. Now, this is really strange. Anybody who knows me well and who knows how much difficulty I have using my phone on my iPad wouldn't put me in that category. Although if it helps, I am beginning to now believe that a platform is something other than the thing you stand on when you're waiting for a train. So I have, over the last few years, I think, learned quite a lot about technology and innovation. I'll come on to that. So I'm going to just give a bit of an overview of what do we need to do and why is this important. Very briefly, why is this important? The NHS plan talks about three things. The NHS stands for moving care downstream, moving care nearer to the patient, and digital innovation. Can I tell you, it's 30 years ago that in Bradford, I was doing some of the things that are mentioned in the NHS plan about doing more preventative work and moving care into the community. It's still vitally important. It's still the big thing, but it isn't new. But digital is. It's not very, very new. I know it's been around for a long time. But if we look at the one thing that I think can make a massive difference to patients and to the cost of the NHS, it's technology and digital. And I think that the widest concepts of technology will probably revolutionise the NHS the way pharma did 30, 40 years ago with their innovations. So it's vitally important. So I'll move now into sort of what's wrong and what can all of us do to help. And I think if I can start, well, before I start, can I just echo a couple of things that have been said? The one thing that I do really want to echo, what was said about NHS innovators and people in the NHS really wanting to do well, and how important it is for industry to recognise they're not dealing with a group of people who don't care about patients. In the NHS, taking us red, that's what we're here for. We're here to help people. We're here to make people healthier. We're here to make poorly people better, which is equally important. But I think, there is a big message here for industry about some of the things they need to change. But there is also a big message about what the NHS needs to change, because although that is true, I think one of the big problems with the NHS is fragmentation. And therefore, your problem is that when you're dealing with the NHS, you can be dealing, how you make the bits join up. And I'll come on to that later. But actually, the one thing I will start with is the whole thing of digital transformation technology. It's an elephant we can't eat. It's not a heterogeneous group of things that are all very similar. And if there's one plea to everybody, whether it's industry or those who I work with in NHS England or NICE or whatever, or those of you in ICBs, it's let's be a bit clearer. Let's have some sort of taxonomy that tells us how we can break technology. And so when we're talking about it, we know which bit we're dealing with, because the pathways are totally different. I've kind of got some examples here. I saw somewhere where they'd broken it down, predictive analytics, personal care delivery, healthcare efficiency, whether it's clinical or admin, remote monitoring, virtual assistance, digital consultation, image analysis, clinical documentation, triage, decision support, surgical precision robotics, implants, and some of those are some things that are a mixture of all those things. So my first plea for everybody is, why can we work on something which gives us there's too many on that list, but broadly tries to find a different way of dealing. If you're dealing with something which is an analytics solution, something that is very different than you're dealing with robotics, and yet we lump it all under digital and technology. My second plea is probably for industry, and I won't repeat what Steve said about, if the problem is you. And, so much of industry, they kind of think they get 3 examples of one patient that's been made a bit better, and that's it. It should be. Everybody should be running towards it. And secondly, it is the kind of understanding of the implication that there is one NHS budget, and the people in the NHS have to deal with everybody out of that budget. And any penny you spend on one thing, if it's not cost effective, it's a penny denying another patient elsewhere. So I think that there is a lot more. Industry actually says, please signpost as to what you want. And I don't think that's easy, because I don't think you sit in a darkened room thinking, what do we want next? I think industry has to kind of work that out for themselves. But I think there could be a huge piece of work to educate industry about what goes on. Because all too often, industry has no understanding of the financial flows, no understanding of how the NHS decisions, no understanding of what matters. And I think we in the NHS have a duty to do this, and industry has a duty to receive that understanding, because unfortunately, the evidence that something can save the NHS huge amounts of money actually it doesn't, does it? Because we've no way of realizing it. You know, there's absolutely no way that when you find a way, it looks like that much money, but if you're sitting there as a DOF in an ICB or a DOF in a trust, you've no way of taking that money out of the service that's already available. So again, I think that real understanding, and we could do more in the NHS to help industry to tap into, you know, because really for us, our currency is pretty much bed days, and it's maybe clinician time as well as that. And we've always got the difficulty that we're looking for an ROI in a year because we've only got a year's money. So how do you work through something that's going to give you an ROI in a year in order to free up enough money to use something that's going to give you an ROI in 3 years and then 5 years and 20? Because we all actually know probably the things that are going to give you an ROI in 20 years that are the best of all. So I think that just education of industry on how things move down the stream is really important. I think then if you start to look at which bits of the system need to do what, I think the centre needs to look to its laurels, because there's so much going on in there at the moment. Industry is just overwhelmed with what they're being asked to do by all these different bodies. My guess is if you're sitting in an ICB or a trust, you're probably overwhelmed with what they're telling you as well. So I think we need a national regulator or national regulators to tell us what's safe. We need those to tell us what's cost effective. But we do need a better, you know, we've got Part 9 in the MedTech Directorate, we've got NICE and its LSAs, we've got NIHR in there, we've got supply chain trying to do information, we've got the HINs. You know, I think the HINs are so important. I haven't got time today, but the role of the HINs has been the pivot, and working out and connecting all this together is absolutely vital. But the commercial directorate in DH, all that lot, they really, really need to come together so that industry knows the sort of which the route to get through this, and then how do we get out into the system. You get out into the system, and then industry, even if it's got through some of those hoops, it's got to have a proof of concept. So how could that be better? And for that, you need local help. You know, they can't do there might be some pots of money in the centre that, if you can find them, will help you with your proof of concept. But you have to get out into the system and use local ICBs and trusts facilitated. Again, big role for HINs here, into how you find your money so that you can work out that something works. And so again, I think it's really important that that more could be done to allow industry to tap into places which would help them with a proof of concept. Once you've got that, and somebody, you know, the point of this thing is, well, how do you get scalability? Because you're then into an even bigger difficulty, I think. And if I think of the sort of places where, sorry, I'm turning the page. Strange being on remote, isn't it? Because you can have your speaking notes behind you. I normally speak without any notes, but it's been a bit of a luxury this morning to have a few prompts behind me. But I think that scalability thing is where probably people in this room from, you know, this has been West Yorkshire ICB and the HIN, and together I think that they can think about how they do that and how they collectively do it nationally. Because there are some things that you need to do nationally and you need one body to do it. There are some things that need to be done nationally, but it needs the group of bodies doing that task to come together to do it, not to be done to them. So, you know, I think if the ICBs get together and do the things that they should be doing, but do it nationally because the 25 of them do it collectively, that's much better than it being done to them. And the HINs, I think HINs individually do great things. I think collaboratively they do some fairly good things. But again, if I was saying anything, I would say that they could be better at doing things collaboratively, because I've got going to have so many examples of where people have perhaps got a grant, have been able to get something going, have done their proof of concept, have actually proved it's okay, but they just can't get the traction to sell it. And that's where we get into you know, you have to have your clinicians on board. If you haven't got your clinicians on board, you're going nowhere. But once you've got your clinicians on board, how do you get past that? And the problem is that often it is a trust often that might have to pay for some of this innovation. And do you know what? They're going to get no benefit from it at all, because it might remove admissions, it might, so what for them? So how do we move from the place where we can get all the people in the room? And, you know, West Yorkshire does this better than most. So if you know, I can see why people come here for innovation. But I can give one example. I work, and I make no suggestion, I'm not promoting this company because I've already started doing a bit with them, but they do sleep apnea. And would you believe they have a big proof of concept in West Yorkshire that was started years ago about how you can do this digitally, how you can do it well. Can they then get the next step into how can we get this into mainstream, even in West Yorkshire? It looks like they can't, and that's because of all these the different pockets of money and the financial flows. So I'm optimistic that as we move forward now, and I don't know whether the ICBs can achieve it, they should, whether we will need to go to IHOs. I think the new model of integrated health organizations should bring providers, as long as they've got primary care providers in there, together to do this. So last of all, if it was me, what would I do? Well, I would do more to educate industry about what they have to prove that A, it's safe, they're good at doing that, B, it's effective, they're not always good at doing that, and C, that it's cost effective, for which they find it really difficult. And I think HINs and ICBs could have a massive role. I would really work hard at bringing together national regulatory bodies so that industry is presented with a roadmap that they can understand. I would find a way of being able to help people do proof of concept better. And again, back to HINs and ICBs collectively. And finally, I think we need one or two front runners, and West Yorkshire is a great example, but they could lead the way and help the others on to say, once where we've got proof of concept, how do we come together? How do we make it not about whose money it is and how it moves, so that collectively we can say, actually, this is going to benefit us. How do we make sure we're looking at the 1 year, we're looking at 3 years, we're looking at the 5, and actually turn something that we've proven works for patients into something that we can also prove works for the taxpayer. Back to you, James.
Fantastic. Thank you, Barbara, for those views and comments there. Really powerful. I think from all three of our speakers today, Steve, Damien, and Barbara, thank you so much for your initial insights there. But you haven't ended there, I'm afraid. You've got a few more questions coming. So what we'd like to do is kind of open up the kind of questions. People either can put their hands up or highlight if they want to ask a question. We have got some questions already, but I suppose to try and summarize a little bit there in terms of what we heard, and we heard some great stuff in terms of what's happened, what's been happening, and then some of the kind of challenges that people have come across there. But essentially, kind of, it's important that kind of when we're looking at innovation, it needs to be kind of usable. We heard about Steve talking about the importance of it being scalable, affordable, and having an interoperability there as well. There, I think you all touched on the fact that kind of baked into this has to be the health inequalities, and making sure we get that. We look at the inequity that we see across our systems there. But actually, what we've also seen from what's been highlighted from Steve and Damien is actually the innovations that we've seen today have really kind of hit hard on that and really made some real impact there. And then there's something around kind of the leadership and the collaboration we heard with Damien, and that leadership really drove kind of the ability for the system to work there. And Barbara then touched on how this is all about making a difference for patients. I think we all did, actually, to be honest, you all did there. But it's about making a difference for patients there. But clarity is required across our system, clarity of what the roles are, what actual digital and technology is there. But again, it's about how we can kind of collaborate there, so that we're fit to kind of meet the new models that are developing across our geographies there. But also so we kind of hit that kind of 10-year plan and life science sector plan. Even if it may have been there 30 years ago, there are some elements that are still new, and actually we need to really kind of attack and appreciate and look at kind of what the solutions are. But all of that, some great work. There were challenges, I think, you all came across and highlighted there. One of the questions we've had is I think it's directed at Steve, but it's for all really. Is Steve, you talked about some of the barriers to innovation in your experience. How do we overcome those challenges and the barriers to embedding innovation into everyday clinical practice? And Steve, I'll send that to you first of all, but others can come in after.
I mean, I'm glad I got the easy one. So I think I would kind of challenge some of the vocab to begin with there. Like, do we even know what everyday clinical practice really means? Do we know what we're kind of shooting for? So the way that I think about it, and again, I'm not from a healthcare background, but I have kind of picked up quite a bit on the journey, is phase one. So phase one is sort of like where we are with West Yorkshire, which is there was a funded project that delivered on some goals, delivered really well, great feedback, great evidence. The money came from the customer, i.e. West Yorkshire. It wasn't a third-party grant funding organisation, so it was a business case got signed off at a kind of, few thousand patient sort of pop level. The challenge then is how to take that into a multi-year, much larger program of work. That's how I think about everyday clinical practice, which is a much larger project. Fundamentally, it will differ from product to product, I suspect. So the one thing that I keep coming back to, and I've said this publicly, is that the system, any system's actually quite good at doing the phase ones. That's actually they're pretty good. I think the big challenge is the transition from phase one as a one-off project funded from an in-year budget to a multi-year project funded from a budget that goes across multiple years is completely opaque. And there is no transparency there whatsoever. And often, actually, though, even from the individuals that you did the phase one project with who work at the system, they don't know fundamentally how to transition that at all. And there's changing budget lines, changing priorities, changing this and changing that. So I think one of the biggest things that I would love to see is real focus on how to drive that phase one to phase two transition in any area, in any clinical area. So if the phase one has gone well, what is the sort of rough agreed stepping stones to getting to a larger phase two? It doesn't mean it's definitely going to happen, but I think a lot more transparency around there would be really, really helpful. Because I think the system often defaults to just doing more pilots because it's kind of easy and it makes everyone feel good about supporting innovation. And that's fine. And that does make people feel great. And it is great to work with really cool, exciting people like Damien, and doing stuff. But it doesn't necessarily change the world unless you can get past phase one. So I'd really focus on more transparency, opacity, drive around phase one to phase two. That's my take on it.
Thanks, Steve. And I agree with you. I think kind of the thoughts about piloting nowadays, it's about how do we really embed this kind of longer term and get the real benefits. I just want Damien, any other thoughts on that at all? You want to come in?
Yeah, I'm with Steve really. I'd say one of our early lessons learned was that when you get grants and funds, if you hand them out free, there's no value in free money, and so it's very hard to get people to take a program seriously if they know that they're not on the hook for it in any way, shape, or form at the end of the day. So we've actually moved our approach entirely. If you're not willing to put at least some skin in the game, and we're not talking huge amounts, but we're kind of saying where we have the funds available, if you're willing to, I mean, ideally match fund, but if it's a percentage, 10% in, we're happy to go with you on that basis because we know that you're going to take it seriously and you're going to try and find a route to sustainability if we're successful. It also means that you're captured on a budget line somewhere. So if you're down as a free fund, you just drop off at the once that fund comes to an end, you drop off and you're not in the financial calculations going forward. So we're very much at least put a percentage of skin in the game so that we're all vested in making this a success.
Great, thanks, Damien. Barbara, I've got another question. Actually, we'll move on from that question. I've got another question from one of our attendees. So, from a system leadership perspective, what is needed to de-risk and accelerate adoption?
Mm-hmm. Well, it's a really tricky one. Actually, I'm going to answer half of that on the back of the last question.
Okay, go for it.
What I'm going to say, and it is the answer to this question as well, in the final analysis, the things that really, really make a difference are changing clinical practice and changing patient or citizen behaviour. That's what it all boils down to, and that applies whether it's a technology or not with a technology. I don't think the NHS invests enough in working out how to do change management. I certainly think we often toss technologies in without the change management techniques that need to go behind it. So what do we need to do? So the question was, what do we need to do at system level to get better adoption? I think that's one of them, because I think unless you've worked out what the changes are, and it's so difficult. Even in getting proof of concept with the technology, it's so much more difficult than it is for pharma and do a double-blind trial and everybody sees the results. It's because you're often changing the clinical path. Any technology is almost certainly changing the pathway as well. I do think one of the biggest barriers, though, is the financial flows and the contracting decisions and everybody coming together to work out how things are done. I think if there is something that really works, and again, I think I already put my challenge out to industry, it's got to really work. It's got to be cost effective, not just effective. But once that happens, we should not be in a scenario whereby people are having to try and work out who's going to pay for it, because who's going to benefit and whose budgets it's going to come out of and what difference it's going to make. So I think that the biggest thing that a system can do to do this is to kind of bring together the relevant players in order that actually, once you've worked out that something really works and really is going to give you a cost-effective benefit. And again, I'm really sorry, it isn't enough for something just to work. We have so much to spend our money on the NHS that if something isn't saving you money as well, it's not going to get a look in. But once you've worked out that it does work, and once it works out to save money, I think there ought to be a forum where you can decide that that is the case, and then the system works out how they're going to move the money around and what they're going to do it, rather than from the outside trying to have to answer that question.
No, I think I'd completely agree with Barbara on that one. And I think that this goes back to the point I was trying to make. And everyone's got different views on Elon Musk, but one of the things that he said when he started Tesla was, like, if you're going to launch something into a category where there's already lots of products, which effectively is what innovators are doing, we're saying there's already an incumbent, then that your thing has to be so much better. It has to be a step change. It can't just be like, oh, it's a bit better. So that's our responsibility. But to Barbara's point, if you as a system are looking to us to explain to you how to adopt things from your system, that's not a question that we can readily answer.
Thanks, Steve. Damon, do you want to say anything at all before I go on to the next question?
I was just going to touch on a couple of bits there. I think a lot of, certainly the health techs that I'm familiar with, they're all willing to put their money where their mouth is on their claims as well. They'll stand by their product and they'll kind of say, look, I'm more than happy to do this at risk and enter some kind of gain share agreement. I do think we could be a bit stronger with different contracting mechanisms that are a bit more flexible, that kind of open up different routes to market for some of these innovators out there, and I think that would help to de-risk some of them for the NHS as well. So I think that's quite. I'd be really keen to see adoptions of different contracting methods that recognise there's a win-win to be had for innovator and the NHS. And then another thing that I'll bang on about until the cows come home is decommissioning. There is no point having a tremendous innovation layered in and not having a plan to then, if it's successful, once it's demonstrated success, to then decommission the old traditional model. And the number of times I get kind of told, oh, we're layering in cost, it is purely because we're not kind of thinking and being brave and kind of saying, right, we now trust in this, let's decommission these elements and bring those out. And very few plans around adoption of technology come with, and here's our plan to decommission the old.
And actually, can I jump in with a really bad example in a health environment on the back of Steve's Elon Musk one? if McDonald's found a way to make crispier fries, and this is a massive organization with franchise, and I cannot tell you, they would be making crispier fries in every outlet all over the world inside 6 months topside. If they could do that, why can't we?
Thank you. Thanks for that. So just taking on to another question we've had around local authority and just involvement, and we've talked about very much the NHS, but actually the 10-year plan, life science sector plan, as we start to develop our integrated neighbourhood teams and as they flourish. And as you've talked about, Steve, in terms of going out into the community in your HGV, but actually, how do we enable kind of the skill sets, and kind of how do we work with the local authorities to help support kind of health innovation there? I just wondered what your views were there, and this is around, well, lots of different areas, but particularly around some of the kind of health inequity gaps that we're seeing, and how we engage that. So over to you, Steve, first of all. That's okay.
I'll take this one, and then I'm so sorry I've got to run to my next thing, but it's been an honor and a privilege to be on, and if anyone wants to follow up, my email is on one of the questions. So so we work quite extensively with local authorities because for one good reason, which is the Healthchtech funding goes through the local authority. That creates some conflict with the ICB, and it's a bit of a weird anachronism at times. But there's plenty of local authority colleagues that are interested in this space. I think the trend that we've seen at local authority is the majority of that gets kind of offloaded to providers, which could be PCNs, it could be the other provider company. So it increases some complexity. But in the most successful systems, we've seen those public health leads on the local authority side be included with ICB colleagues and PocDoc, and in some instances, many instances, to talk about how to increase rates of CVD screening in certain populations in certain places. So I think, to the point that I can't remember who made it, ultimately, if the system or the region believes it has a problem, then getting a multidisciplinary team together, irrespective of where the funding comes from, your bank account, my bank account, whatever, getting them together to figure out exactly how we're going to solve this is really the ideal way to run a project, fundamentally. And I'd love it to happen more often. So I don't quite know if that's a relevant answer, but where it does happen, it ends up working really, really, really well in our experience.
Thank you, Steve. And if you've got to go off, thank you very much for your contribution today. It's been fantastic. Thank you. Damien or Barbara, is there any comments on that at all in terms of how we work with local authority and closer for health benefits?
You go first, Barbara. I'll come in.
The only thing I always say when I did things about working with local authorities, it's another elephant we can't eat. And I always try and break down the sort of, what do we mean by working with local authorities? Where are the areas? And I do think there are several where, so I think there's a lot of innovation that could be done across the provision of care. So that's when you get into the social care, healthcare, where they're provided jointly. We're often talking about frail elderly, so there's a lot you can do there. There's that joint agenda on public health and the health inequalities, which is a different one. And I think Steve's already covered some of that and how you can do that. There's the kind of joint working on commissioning. So where can, there will be ways, there will be cohorts of patients where some joint commissioning from local authority and health can do it. So I think the answer to that one is kind of which of those categories does it fall into, and then how can you tailor the joint working to make it work?
Yeah, not much further to add there, James. I think it's certainly a lot more exciting from our perspective at the moment, seeing the kind of the life sciences sector plan start to come to fruition. And we've started to see much more kind of joined up working across a huge number of government organisations, including local health authorities. And I think starting to think more holistically around how does this benefit UK PLC, and I think that's something that we often miss, which is, if the NHS is investing in us as an innovation, if we're then getting the data out of an incredible kind of initiative across a population, there's something there that we're generating that we can sell to the rest of the world, and how do we make sure that's a win for the innovator and a win for that initial investment from the NHS, and really bring UK PLC right out to the globe.
Yeah, no, thank you, Damien. I think that's really key point about UK PLC, and it's greater focus. And I think across West Yorkshire Health Innovation Network, we're working really closely with our West Yorkshire Combined Authority across the hubs and the innovation networks there as well, to kind of make sure we can benefit from that, not just from West Yorkshire attracting in people, but kind of supporting the UK with that there as well. So thanks for that. Last couple of questions, if we can there. So, because we've got all sorts of sectors on here today. So, we've got someone from the higher educational sector, really, in terms of, I mean, you've talked about how it's important to kind of engage with our clinicians, engage with people using it. But how do we better prepare the current and future health and care workers to integrate this emerging technology into practice? And I suppose, any thoughts on that? Because kind of some of the discussions have been around kind of just implementing it out there with the current clinicians, but any thoughts in education?
Yeah, I think Barbara really hit on it earlier when she mentioned we underinvest in change management. So, and sometimes that is the innovator's fault. So I can tell you that right at the start, we were like, we've got the most amazing product here. We're going to drop it in. It'll just, incredible usability. Drop it in. It'll work. It doesn't work like that. You need to bleed. You need to bleed into the pathway at either end for something to engage, and people have to be comfortable. There's education not only around the use of that product, but there's how does it fit into the pathway? How can I be assured that it's going to deliver what it needs to deliver, and it's fully evidence based, and the efficacy is all correct. I'd say that we wouldn't hit that kind of that number of 63% in West Yorkshire if we hadn't been engaging with the staff throughout. And the feedback that we've had, where they've kind of said, rather than go out for a broad hypertension cohort, let's do a narrowed cohort. Have you thought about the influx of patients on the back of results? So we staggered all of our tests, so that rather than send out 1,000 tests in one GP practice all at one time, and then you've got 600 people saying, "Oh gosh, I've been flagged as having potential chronic kidney disease. What do I do?" We started to amend our model. All of that is from working with the workforce, understanding the change management required in that pathway, and that's really got us to where we are today. But I think ultimately, do not underestimate how much change management and how much engagement is required to make a product stick.
Thanks, David. Any comments, Barbara?
I think there is the obvious answer, which is, if we're going to expect people to be able to use technology to have a much better understanding of data and analytics, we can the health education and the agendas for that need to make sure they encompass that. But I think there is perhaps a sort of slightly higher level question for health education. It is, what are we educating clinical professionals for? Because in my day, I think it's a long time ago, my education taught me how to make poorly people better. End of. Now, I think we've kind of changed to the point where we've actually got a workforce that is educated to also keep people healthier. I think we have edged into the making the clinical workforce understand their responsibility to the taxpayer and the nation. I mean, that's a big one, and that was really, when fund holding that's what I learned in the days of fund holding, because most clinicians, in fairness, their only priority is the patient in front of them. But this is the workforce that spends all our money. So if they're not educated to have a responsibility for that overall sum that we're allowed to spend on the NHS, and then I think the education of them that innovation is their role too, that actually just doing what you've always done is not part. So that's what my challenge would be to educators. How do you make sure that we're educating the workforce to do all of those things?
Great, thank you both of you there. So last couple of minutes there. So I just thought I'd ask in terms of, so Damien, you picked an area with Healthy IO and kidney disease there. It's clearly a significant health priority. It is for West Yorkshire, I'm sure it is for other areas as well there. And you've kind of picked up on that. Barbara talked about collaboration and really understanding your systems and working with your systems there. So I just wondered, in terms of when you start off on this as on that discussion in terms of making sure you're aligning with health priorities, because so often as a leader within the system there, people come and say, you need this, you absolutely need this, but actually, hang on a minute, no, we don't. Our health priorities are X, Y, and Z. So I just wondered your thoughts, your reflections on that, and then maybe Barbara, from a system point of view, your reflections.
Do your research, right? You've got to find out. So there's no point banging on someone's door if it's not a pain point for them. And so who is really suffering? Now we're very fortunate, really, in that there's a national diabetes audit undertaken annually that shows where people's adherence to ACR testing is limited. But I'd always kind of advocate for good real research, understand the pain, understand the problem, and then progress on that basis with the solution. We wouldn't chase down someone that hadn't got an issue around chronic kidney disease emerging. I don't think there's any more than that, really, James. Just good research.
Yeah, thanks. Barbara, any thoughts at all?
Well, just a couple. I mean, it is really difficult about priorities and common things are common. And I always used to get frustrated. Still do get a bit frustrated about, we've got a different set of priorities here than another place. You might have a priority about how you deal with things, but as far as I can work out, there is no ICB, no place in the country that hasn't got a big problem with diabetes and heart disease, and probably very few where Rocky Mountain spotted fever is causing them to lose sleep at night. So I think that, the first thing, let's everybody accept that you have to go over we're all in the same boat, and there should be some big national priorities that we go after. However, there are some rare diseases, there are many rarer diseases whereby, it's really important for those individuals, and we can't shut them out just because they're not common. And that takes back to the Damien things. If you have evidence, and I think everybody has to be alert, yes, go after the biggies, because that's where you get most bangs for your buck. That's where you do the most good for the most people. But if something actually is better for a patient and can show a way to not costing more money, then it is absolutely vital that the NHS has that flexibility to be able to look after the common and look after the rare.
Thank you, Barbara, and thank you, Damien. So we sadly have come to the end of the session there. So I don't think there are any other questions we've got at the moment there, but I suppose I just want to first of all thank our speakers. Steve, who's had to leave us, but Damien and Barbara, thank you so much for your input and your insights today. It's been fantastic to really hear some of the work that's happened, some of the challenges you've had, some of the opportunities you've taken there as well, and then the insights from at different levels, and understanding the key areas, I think, in terms of helping others to get those innovations into practice. I think we've heard a lot today about making sure it's usable, making sure looking at how we scale things, how it's affordable, how we make sure it's interoperable with our systems there, and how we are having the inequities balanced out there. And that's around about the leadership within the innovators, leadership within the system, and the leadership within our clinicians and healthcare providers there. And I think the real I think there are some challenges you've posed us in terms of, I think, this piloting phase and how we get from phase 1 into phase 2, and having that understanding around the clarity of those next steps. So that we're not left on a cliff edge in terms of, are they going to commission this or not there. If it makes a difference for the patients, if it makes a difference for the healthcare users, it's having the impacts that we want to see. It's a priority for our systems there. Then the question is, why not? However, I think we recognise that Damien highlighted an area in terms of, well, we're not good at stopping things as well. So there are opportunities to enable that funding to move, but I think we've got to be better at also stopping things that are not working, and we've just got used to it there. But I just so thank you so much for your your insights there. Thank you to the audience for your contributions and your questions there. I think hopefully we kind of helped with reinforcing how innovation can support better outcomes for both staff and our communities, and some really good examples we've seen today there. I think there will be, and also want to thank those behind the scenes who've been supporting me, supporting us in terms of producing today's session there, but other sessions as well. An awful lot of work goes into this in order to make sure we kind of are able to do this for everyone there. Let you know that the recording will be shared after the event on the various comms platforms there. There will be further, as I said, this is the fourth of many distinguished lectures, and the lecture series will continue. Further dates will be confirmed probably towards the end of January. Will be the next one there. Really important that you stay connected with us so that we can kind of make sure that we are kind of sharing our kind of information out. People get the opportunity to link in as well there. You will, and also just to make sure that as I said, the fifth session will be shared out. Hopefully, I think for relatively soon there. So on that note, can I just thank you all again? Thanks everyone. Appreciate, this is the first time I'm going to say it, but I appreciate you hope you all have a very Merry Christmas. If people were on here beforehand, they'll catch that various people are jetting off to various places, and there's countdown for various people there. But I hope everyone managed to have some time off over the Christmas and New Year with your families and friends, and have a festive period there. And I'll see you at the next one of these if you attend there. But thank you very much all.
Thanks ever so much. Lovely to see you all.
Take
Take care. Bye-bye.